Good afternoon, everyone, and welcome. I'm Najla Nasri from Johns Hopkins, and today we're fortunate to have Dr. Stephen Durning moderating a special journal club session that'll feature Dr. Abigail Konopasky, who will be presenting her article on context specificity, and Dr. Alan Schwartz presenting his manuscript on the use of standardized patients to study diagnosis. It'll be a great session, so thank you all for joining. So to orient everyone, the goals of our journal club are to generate novel discussions on scholarship and academic development, to discuss ideas for new research methodologies and projects that may be inspired by the content presented today, and to promote collaboration. The session format will include brief presentations, which will be followed by a discussion that'll be moderated by Dr. Durning. Now on to today's presentation. I'm pleased to introduce today's moderator, Dr. Stephen Durning. He's a professor of medicine and pathology and the founding director of the Center for Health Professions Education at the Uniformed Services University. He received his MD degree from the University of Pittsburgh and his PhD in Health Professions Education in the Netherlands. Dr. Durning has published more than 275 peer-reviewed manuscripts, more than 50 book chapters, and he has written 5 books. His research interests include clinical reasoning, education theory, and individual and program assessment. Welcome, Dr. Durning, and thank you so much for moderating today. We'll turn over the slides to you.
Thank you. It's wonderful to be with you all today, and I hope that this is a very engaging and exciting session for everyone. I wanted to start with just a couple of housekeeping items for us to mention. First, if you have any questions, which we hope you have several, you can ask questions in the chat box or by raising your hand or letting us know some other way. And also note that the 2 papers for today's discussion are also in the chat box for you. We'll have time after each presentation for Q&A, and we'll also have a larger time at the end for questions and answers. So we're really excited about this opportunity today. Next slide. So I have the pleasure of introducing our 2 esteemed speakers for today. The first is Dr. Abigail Konopasky, who's an assistant professor of medicine in our new Center for Health Professions Education at the Uniformed Services University. She is a doctor, receiving 1 PhD in educational psychology from George Mason University, where she developed functional linguistics tools to explore learner agency, and a 2nd PhD in linguistics from Princeton University, where she studied language structure. Dr. Konopasky is very active in the HPE Center, mentoring graduate students, teaching and advising multiple courses, and working with learners across the continuum to include advising medical students in our new special interest group called Health Education Interest Group for Higher Training, or HITE. Her research interests include agency, functional linguistics, clinical reasoning, qualitative and mixed method approaches to research. And our second presenter, which we're delighted to have today, is Dr. Alan Schwartz, who is principal and co-founder of the Institute for Practice and Provider Performance Improvement Incorporated, or I3PI, which seeks to improve healthcare quality and cost through direct observation. He holds a PhD in cognitive psychology and an MS in organizational behavior and industrial relations from the University of California at Berkeley. Dr. Schwartz is also the Michael Reese Endowed Professor of Medical Education and the interim head of the University of Illinois at Chicago Department of Medical Education, as well as research professor in the UIC Department of Pediatrics. And for those of you that are affiliated with degree programs, you know how strong a gold standard that UIC represents. So really excited to have both of these presenters today. So Abby will begin with presenting her paper, Understanding Context Specificity, the Effect of Contextual Factors on Clinical Reasoning. Again, we'll have some time for questions and answers following that. And then Alan will present on direct observation of depression screening, identifying diagnostic error and improving accuracy for unannounced standardized patients. Dr. Konopasky, are you ready to take things over?
I am indeed. I'm going to try sharing my screen. So let's see. All right. Can you all see that?
Yes.
Yes.
Perfect. All right. Let me just get to the presenting mode here. Wonderful. Well, thank you, Steve. And I have to say, it's nice of you all to call it my paper, but I would like to point out that this was the result of a large and wonderful team of scholars who came together to really make this work happen. I'm, as Steve said, an HP scholar at USU, and I've got a background in mixed methods and linguistics. And so today I want to talk to you a little bit about contextual factors and context specificity. Let's see. Okay. So clinical reasoning, which, as you all know, is a complex process of weighing the evidence, is affected by a number of different factors or processes. One of these is case specificity, and this is the idea of different types of cases, for instance, diabetes versus angina, leading to differential performance, right? So depending upon the content of the case, that a single physician might perform differently. Then there's the idea of context specificity. And the idea of context specificity is that something other than the case content affects physician performance. So some kind of inhibiting contextual factor like sleepiness, diagnostic suggestion, patient frustration, that one of those things that has nothing to do with the content of the case might affect physician performance. And related to context specificity is this idea of cognitive load. And cognitive load is constraints on working memory, this idea that there's only so much we can hold in our head at the same time, and that perhaps one mechanism by which these contextual factors do their work is by creating high cognitive load. So, sorry, here we go. So we approach this through the theory of situated cognition. And situated cognition views contextual reasoning or clinical reasoning not just as something that's in an individual provider's head, but instead as something that encompasses the whole clinical context, right? So you have the physician themselves and things like their sleepiness, maybe they're burned out, level of expertise, are they experiencing cognitive load? Then you have various patient factors as well, right? So is the patient frustrated? Is there some kind of diagnostic suggestion coming from the patient? Is there a difficulty with English or communicating? And then also the factors of the encounter. So is the appointment long enough? What's the setting? And is the setting something that the physician is used to practicing in? How functional is the electronic health record? So in a situated cognition approach, all of these factors play into what we call clinical reasoning. And we are particularly interested in this study in those in red. So a couple of physician factors and a couple of patient factors that we look at in this study. So our research questions, is there a difference in clinical reasoning performance as measured by open-ended diagnostic questions? We're going to talk about those in a minute. When physicians diagnose the cases with and without contextual factors. Similarly, because we think it's one of the mechanisms behind context specificity, we're interested in whether there's a difference in self-rated cognitive load, which we talk about as mental effort in this paper, when physicians diagnose cases with and without contextual factors. So this is the study design. For every participant, who are internal medicine physicians, participated in two cases, one with contextual factors and one without contextual factors. And they had both a diabetes mellitus case and an angina case. And we did two between individual comparisons. So we looked at, for the diabetes mellitus case, we looked at those we had 8 residents and 7 attendings who did the case with no contextual factors at all. And then we had 24 participants where for them, the patient had low English proficiency and was questioning the physician's credentials. And these were video cases that these physicians were seeing. For comparison 2, we looked at those 24 folks who had the angina case without contextual factors, and then those 15 folks who had contextual factors in the case, which included diagnostic suggestion and a circuitous history. So that was the design of the study. For our instruments, we used the post and counter form, which we've used in prior work. And what this is free text questions about different aspects of diagnosis, the leading diagnosis, differential diagnosis, problem list, supporting evidence. Are there additional exam actions you would take? Are there additional history questions you would ask? And we chose this because it's authentic. It has a feel a little bit like notes, and it rather than being an ABCD, which I understand that UMDs don't get like a multiple choice when a patient comes in, which is a bummer, which is why I don't do that. So it allows it to be more authentic and include more of the reasoning. So these were scored as correct, partially correct, or incorrect, and that was done by consensus with a team of internal medicine doctors. We also used a single item 10-point scale measure of cognitive load, sort of from low to high. How much mental effort did you put into this? Did you find this to tax you with? And that was our measure for cognitive load. We had 39 participants in internal medicine. They were practicing physicians, attendings, and residents at a military medical facility, ranging in age from 26 to 55 years old and ranging in years in practice from 0 to 24. So we had a number of interns as well. That's how we get the 0. And we received IRB approval for this. So these are the results. We ran a MANOVA, and what that showed was that for the angina case, there was significant difference in performance on the PEF for those physicians who did the angina case without a contextual factor and those physicians who did the angina case with a contextual factor. And as expected, those physicians who did the angina case with a contextual factor did worse. And you can see I've bolded their scores, which are percentage scores that were calculated based on, out of the possible points, how many did they earn. And as you can see, there's a significant difference in the percentage points, particularly around additional exam actions, leading diagnosis, and supporting evidence. Those were some of the bigger ones. And note that this is controlling for years of practice. Expertise on the whole did not make this difference go away, although we did notice a significant difference on the additional history. What additional history questions would you ask and what additional exam actions would you perform? That those with more experience or with more years in practice did better on those, but those were the only ones. The diabetes case, when we ran the MANOVA, there were in fact there was not a significant difference among the two sets of scores for the diabetes case without contextual factors and the diabetes case with contextual factors. Essentially about the same performance in both. And then this is similar to what we got for cognitive load. There was not a significant difference in cognitive load self-ratings for the contextual factors case or no contextual factors case, but we did note a trend where folks had slightly higher cognitive load for the contextual factors case in both diabetes and angina, but it was not significant. So conclusions. Well, this was the first study to use a free text authentic outcome measure to experimentally demonstrate the effects of contextual factors on clinical reasoning with a control group to take a look at this. And what we found is that contextual factors significantly affect performance on this PEF across all expertise levels, but only in the angina case. And so the next steps for discussion and thought and research are why, and one of the reasons we wonder about the difference between the angina and the diabetes case may have something to do with that case specificity, case content, could have something to do with acuity. With this patient with the angina, if you sent that patient home, it wouldn't be the greatest thing. If you sent the diabetes patient home, it wouldn't be too terrible. So maybe that issue of acuity was part of it. Could it have to do with the types of contextual factors we had for each case? Perhaps diagnostic suggestion and circuitous history created more cognitive load or more distraction than low English proficiency and questioning credentials. Was there inadequate power? And we definitely had a power problem. As those of you all who do research in clinical reasoning know, recruiting busy physicians to sit down and do simulated cases for a couple hours is not an easy ask. So it might have had to do with that as well. We also, as I noted, had no difference in cognitive load, and similar questions there. Did it have to do with our single item measure, although that measure had picked up differences in the past? Perhaps for this particular group, it was not sensitive enough, needed more items. And wondering if there's another mechanism beyond cognitive load. Is it simply emotional reactions that are causing this difference? And then again, that question about power. But the broad conclusion here is that theoretical lens matters. This situated cognition framework allowed us to see aspects of the clinical situation and of the clinical reasoning environment that allowed us to measure things that we might not have measured before, and to really see that context matters. Thank you very much. And I think we're going to do a few questions now, and then after Alan goes, and then we might have a broader discussion. Is that right, Steve?
That would be correct, Abby, and thank you for that presentation. Very helpful, and we are getting some questions in the chat. But I was wondering if I could just start with one quick question, Abby, and this would be a two-part question. The first part is, could you, were there significant effects? As you said, it's statistically significant. Were the effects clinically significant? Could you give a sense of how large the differences were? And a second question to that, if I may, is, any thoughts on what physicians might do to mitigate the effects of context specificity as you've outlined?
That's a great question. And in fact, there are some differences across, when you look across these different aspects of the PEF, you see that last partial eta squared is a measure of how large the differences are, which is that last column there over on the right. And you'll see that perhaps for additional history, what additional history would you ask? And for differential, same thing, maybe not a large difference, but for the leading diagnosis, supporting evidence, and additional exam actions, for sure, that difference is large and clinically significant. In terms of determining what additional exam actions to take, determining what the leading diagnosis was correctly, and reasoning through the supporting evidence for that diagnosis, we did find large differences. And then I think in terms of steps to take, some of our qualitative research and our papers that looked more at the language that physicians used when they talked about these cases showed that in the contextual factors cases, they were focusing less on the reasoning and the case content and trying to reason through the problem. And they were focusing a lot of their energy and time on affective things, right? Their own emotions, the emotions of the participants, and on sort of the contextual factors themselves and how they might sort of solve them or fix them or grapple with them. So I think in terms of advice for physicians, one thing that we think is important is to just be aware of these contextual factors and that they may be shifting your focus. And just an awareness of that focus shift can allow you to shift it back. I also know there's some great work being done on sort of the stop and think kind of moment of, can you stop, take a beat, and either on your own or with a colleague, just make sure that you're thinking through things as fully as you want to.
Great, thank you, Abby. And I know we have a number of questions in the chat box, so thank you, team, for those. I didn't know if we could go up to the top of the chat. And I think the first question that we have here, Abby, is years of practice a good proxy for disease-specific expertise?
That's a really good question. And I'm trying to remember, because we didn't see difference in performance in the diabetes case, it was hard to see if those who had more expertise or more years in practice did better in the diabetes case. They definitely did better in the angina case. I think a different design would get at that, but I would imagine that that would be true. Although we did also control for how frequently folks had seen these different types of cases, and that did not seem to make much of a difference.
Yeah, thank you, Abby. And I think to that excellent question, some of the work from Anders Ericsson that talks about the number of times that you may have seen a patient with that condition within, say, the last week versus the last month may be a good way of getting at this disease-specific expertise proxy and related conditions, which to really have good information will require access to their EHR and the patients they've seen. So we have the next question. It was interesting to compare a symptom, angina, with a diagnosis of diabetes. Now, I believe the case was unstable angina, which is
my apology.
And that may help. Hopefully that helps with the question from Matt. Please let us know if not. As it was a diagnosis, two diagnoses being compared. And John Eli has a question that he did not type in. Is John on the line that can?
Yes, can you hear me?
I can hear you great, thank you.
Okay. This is a little bit in follow-up to Steve Durning's question about implications for practice. So two things. One is, had you had any thoughts about carrying out this study in real life? In other words, sitting in on emergency room visits or clinic visits to either do an observational study with the identical question that you had, but or do an interventional study like a randomized trial of some intervention to help with contextual factors. The other concern I have is that when people have looked at what we call affective bias, sort of the physician anger, frustration, sleepiness, and so on, particularly with anger, physicians are very bad at recognizing when this is happening in real time. And at least that's my impression. And I wondered if you know of any data that has found remedies for this affective bias problem among physicians.
Right. Thank you so much. That's a great series of questions. In terms of the study, we also did a component of this using simulation. And the bonus to that, as opposed to, say, a busy ER, is that we were really able to control for the case content in ways that you can't tell someone coming in the ER what kind of problem you want them to have. So that actually was great. The problem, again, though, was getting enough power to be able to see the difference. Although we did note that, and then let me also say that with the simulated cases, what we noticed is that depending upon the physician, even with the control of the simulated cases, sort of additional types of contextual factors would emerge. So it was difficult. It was difficult to tease that out in large part because of our sample size. But the idea of an intervention, we did develop an intervention in the same issue of Diagnosis, published it. We didn't see a significant difference in our intervention group and our control group, but the intervention we designed did just what I had suggested earlier, which was getting folks to notice contextual factors, think about them, talk about them, and then and then go into a case and see if they could be a little bit more aware of that. It was a very brief intervention, like 20 minutes. But I suspect, especially given the comments people made, that with a little more time and a longer intervention, that might make a difference. In terms of the affective bias, I know that in particular anger has the effect of narrowing diagnoses, whereas I know something like fear or sadness has the effect of broadening diagnoses, and those two different types of emotions they talk about. And I am not I am sure there is some research out there on that, but I am not aware of it. So my apologies.
Well, thank you, Abby, and thank you, John, for the question, everybody for the questions so far. I'm going to ask, just so we make sure that we have enough time for the second presentation and then a larger discussion, that we transition over to Dr. Schwartz's presentation. Alan, are you ready to roll?
Yes, I am. Let me get the screen sharing up. There we go. Hopefully you're seeing slides.
I am not yet.
You are not. That's interesting. Okay. Give me just a moment. We'll try to figure out why not.
There's an extra little I approve window that might be hiding under your slides.
I'm looking at saying something about there being something on top of my slides that has to be moved away. So I'm trying to move it away.
Okay.
Any better?
We can see it now.
Okay, great. Good. So I'm so happy to be here to talk to you all about this work. This is work that's done with my colleagues at I3PI, as well as with Steve Peskin at Horizon Blue Cross Blue Shield, funded by the Robert Wood Johnson Foundation, and in collaboration with the American College of Physicians. So we've been thinking a lot about how we currently assess care. And in particular, two approaches that have been used quite a bit, of course, are to look at the medical record or claims data and ask whether people are doing what we think they should be doing. But there's been a bunch of research suggesting that the medical record and claims data may not, in fact, be accurate, that we may be measuring the wrong things. The other thing we do, of course, is survey patients and ask them about their healthcare experiences. But patients are not always experts in healthcare. Otherwise, they might not be going to see a physician. And also, they make decisions about whether or not to respond to these kinds of experience of care surveys that create some doubt about who the respondents are and whether they really represent what's going on in a clinical encounter. So our approach has been to use direct observation. We do this in a couple of different ways, but predominantly by unannounced standardized patients. So these are actors, professional actors who are trained to present to physicians in their offices as real patients. They're given scripts that we can manipulate to test various aspects of care. And they carry concealed recorders and fill out checklists so that we get documentation of what actually takes place during a visit. We also receive from the practices we work with the physician's note, and that lets us also correlate what goes on in the visit to the documentation of that visit. So the aim of this project was to look at the impact of doing this kind of direct observation and providing feedback to the providers who are engaged on changing some targeted care behaviors, some things that these practices and Horizon, who was one of their payers, had agreed would be good things for them to work on, to look at fidelity of documentation, and to look at cost of care delivered to actual patients as a result of participating in this unannounced standardized patient program. There are a couple of papers that have come out of this study. I'm focusing today on the paper in Diagnosis, which focuses on the diagnosis of depression. So depression, of course, is important. It's a widespread condition. It's also been shown to be quite underdiagnosed. There's been some studies suggesting that even when people see their primary care providers within the last 30 days, when they certainly should have been diagnosed with depression if they had it, because depression screening is recommended now at every primary care visit, in many cases that doesn't happen, and we don't always know why. But people show up in the emergency department with serious depression or attempted suicide, and yet they had seen their doctor recently, and that seems like a problem. So what we did was we trained actors and sent them to make 217 visits. They visited 22 practices in New Jersey, 59 total providers. This took place between 2017 and 2019, about 18 months. We had 4 different case scripts that looked at a variety of different kinds of things that we were interested in. In particular, though, they all presented an opportunity for depression screening, and that's what I'm going to talk about today. Each provider we targeted them to get 4 visits, 1 from each case script. 2 visits we considered baseline. Then we gave feedback to the providers in writing and by phone about their performance on those visits. And then we scheduled 2 follow-up visits so we could look to see whether there was any change overall in the performance of the providers. So in a visit, the actor shows up. They do whatever you do when you're a patient presenting to a physician for a new visit. They fill out all the paperwork. We get a copy of that as well, and that turns out to be important. I'll explain later on. They go, they have the visit, they bring back the audio recording as well as a checklist that they complete about what the provider did. We have coders who listen to the audio recording and code it for things that we expect the providers to do, and then we examine the provider notes. And as I'll explain later, there was also a component of this project that looked at costs of claims that were made by actual patients of the providers for the 3 months prior to their participation in this and 3 months after they had received the feedback. So we could see whether some of these behaviors might translate from behaviors that we see with actors to behaviors that we might be able to ferret out in the kind of care they were providing and the claims that resulted from that care. So in every case, as I mentioned, we expected depression screening to take place because it is recommended. We considered them to be screened if they were screened in pre-visit paperwork. So if someone handed them some forms and that included, say, the PHQ-9, we said, okay, you screen them for depression. They could be screened by the medical assistant or the nurse, or they could be screened by the provider themselves. In 2 of the scripts, the actors would have screened positive for depression, and we were interested in seeing whether the provider made a diagnosis of depression, whether that was reflected in the note. What did they do about it? Did they refer them to some kind of mental health? In 1 of those 2 cases, so in a quarter of the visits, the actor was also trained to be resistant to a referral to a mental health provider. And we were interested in whether their primary care provider probed that resistance, tried to figure out why they didn't want to see a psychologist or psychiatrist and address that in some way. So here's a picture of the results. These are care behaviors. So these are measured by the audio recordings, what we actually heard go on in these visits. And you can see the salmon-colored lines represent the pre-visits, and the blue or cyan-colored lines represent the post-visits. We did find that depression screening increased as a result of being given feedback. So the visits that took place after feedback were more likely to have a depression screen performed than those before feedback. And that makes sense from a QI perspective, because if a practice was not doing a good job of screening, the feedback mentioned to them, hey, you're not really screening everyone for depression. You might want to try to figure out what's going on there. We didn't see significant effects of the other care behaviors. That is, referral increased, but not quite enough to be a significant increase. And in terms of the probing resistance to mental health counseling, we didn't see differences pre to post, in part perhaps because that was a smaller number of cases. In terms of chart fidelity, I'm not going to spend a long time on this, but there are some sort of dramatic and striking results here. In this picture, red is bad. Red means something was not done during the visit, but it was documented as being done in the chart. So that's fictitious documentation. The chart says we did a psychiatric review of systems, or we discussed screening results. But the audio recording reveals that no such thing happened. The gray are things that we had hoped would happen, didn't, but also weren't documented. So those are just missed opportunities. The yellow are things that the providers did that we expected and hoped they would do, but they did not chart. So there's a lost opportunity to document a proper care behavior. And then the green are things that were both performed and documented. Depression-related chartable items were more likely to be performed after the feedback than in the visits before the feedback. But when they weren't performed, they were just as likely to be fictitiously documented before than after feedback. So that is, we may have made it more likely that some things happened, but we didn't make it any more likely that people didn't fictitiously document that things happened. Finally, a look at the claims from actual patients. So we had to look at about 30,000 actual visits, as I mentioned before and after they had gone through this part of the study, and looked at depression-related diagnostic claims. That's what you see on the left panel, the first panel. And those did increase pre to post-intervention in our study group as compared to a control group of practices that did not participate in this project, but that were matched with the practices that did based on location and volume of claims. So we think that practices who participated began to diagnose depression more frequently in the actual patients they saw as well. And then we looked at the cost per claim, and these are only in-office costs related to diabetes. And we found that the costs per claim also went down in our group. Now, we don't have medication costs. So one of the things we think is going on here is if you're doing a better job of diagnosing depression, hopefully you are either referring folks to mental health counselors, or if you are prepared to prescribe, perhaps you're prescribing. What we're not seeing are the large costs that are associated with things like hospitalization for depression-related conditions. There are some obvious limitations in this study. The practices that agreed to participate and the providers that agreed to participate, were volunteers. So these practices, may not represent all practices in New Jersey or all practices that work with Horizon. They may be more amenable, for example, to change or more innovative. And with regard to the claims data, as I mentioned, the only claims we had access to were claims for services provided in office. So unless a medication was administered during a clinic visit, we wouldn't know about it. So we can't see whether, for example, more people were given more depression medications, prescriptions for depression medications, which was something we would also have expected and hoped to see. To wrap up, we know that universal depression screening is recommended. Just telling providers that depression screening should be done at every visit clearly does not reliably result in it happening. We did not find that there was a very high rate of depression screening overall. Reasons for failing to note when a patient is depressed when they are screened. So in those cases where our actors screened positive, but the physician never dealt with it, those reasons really varied by practice. And these are some opportunities to try to reduce diagnostic error. In some cases, the screening tools weren't very good. They weren't the right screening tools. So our actors weren't, in fact, looking depressed because they weren't being asked the right questions. They were just being asked things like, how have you been feeling in the last week? In many cases, tools were provided prior to the visit, like in the pre-visit paperwork, but for one system reason or another, never made it to the provider. So the provider never saw the results of the screen and thus couldn't do anything about them. And then in some cases, the provider did see the results of the screen. In some cases, they even had them in their chart or in their note, but didn't do anything about it. And those are opportunities that I think deserve further attention. It may be that they were concerned with other aspects of the visit, but these cases were designed so that there was certainly sufficient time in these visits for those providers that did address depression to do so, and other providers could have. So I will stop there. Turn it back to Steve.
Thank you, Alan, for that thoughtful presentation. And we have a number of questions in the chat, which is really great. But I was wondering if I could just kick off with hopefully a fairly brief question for you, Alan,
Sure.
Just thinking about your work in general, which is very exciting. Perhaps you can provide some insight to us of how did you get the physicians to be willing to participate in such a study?
Great question. Yeah, I think we often get asked that. So we have some rules about how we do our research, whether it's research that we're doing with our academic hats on or our commercial hats on. It always has to be safe for the physicians. It always has to provide value to the physicians. To be safe for the physicians, what we do is we let them know that this is not going to be shared with your boss. No identified data is being shared with the insurance company. This is a QI intervention for you. We're going to give you feedback and nobody else. So that's the first thing, is assuring that. The second thing is providing value. We're going to give you feedback that we think will help you do what you want to do better, which is take care of patients. We also provide MOC Part 4 credit from the Board of Internal Medicine, the Board of Family Medicine, which I'm sure is an incentive as well.
Great. Thank you, Alan, for that. So if I turn to the chat, there were a couple of questions from David that I'll provide to you, Alan, to comment on, which gets some of the feasibility. So how many actors were required? Realistically, what's the largest number of actors that could reasonably be trained for such a large study? In the COVID era, how easy for actors to convert over to televisits? So a three-part question, if you don't mind, Alan, to that.
Sure. I think we ended up using about 18 actors in total. And part of the reason, normally we wouldn't have needed quite so many. Usually we need about twice as many actors as cases. But New Jersey turns out to be a very big state. And there's a lot of practices that are clustered in the north and others that are clustered in the south. And it takes, with traffic, a couple hours to drive between there. So we had clusters of actors that were based in northern and southern New Jersey, so that we didn't have to, deal with them having to drive a long way to each of the appointments. Realistically, what's the largest number of actors that could be trained? I don't know the answer to that question. We certainly could have trained plenty more if we had needed them. There are lots of people who are already working as standardized patients in medical schools, many of whom are professional actors doing it as a side gig, and are available for training for this kind of unannounced standardized patient work, which does require some additional special skills. And then converting over to televisits, great question. We're really interested in that right now. So we're actually pursuing several opportunities where we hope to begin to do some televisits of unannounced standardized patients. It's much easier, as you might imagine, when they don't have to show up in person, do the travel, and do some of the subterfuge that's required to be a fake patient and to secretly record a visit.
Great, thank you. Another question, was fictitious document provider specific?
Well, because we only had 4 cases per provider, 2 pre and 2 post, we didn't spend a lot of time and have a lot of ability to look and say, can we identify which provider is doing certain kinds of things? We were really focused on the aggregate. We weren't powered to give individual assessments. So we haven't looked to see whether we could identify, a particular provider or a particular practice that looked like they were more likely to do fictitious documentation. I imagine you would find that clusters, not because some providers are less ethical than others, but because a lot of that, I think, is driven by the way the electronic medical record is set up. So if you have templates that pre-check all of your review of systems, and you have to go in there and manually uncheck that you didn't do the psychiatric review of systems, that's going to be hard, and we're going to see a lot of fictitious documentation, whether it's intended or not. Right? We know that from psychology. Right? We know that from behavioral economics. That when the default is on, there's effort to change that default.
Yeah. And a related question to that, if I may, Alan, that was posted by Dan, gets at documenting something that wasn't done in about a fourth of the cases is outrageous. And looking at these at more detail, do you have thoughts on what should be the next step in evaluating the prevalence of these and looking for ways to reduce them?
Yeah, we actually put out a paper with our VA hats on not long ago about omission and commission and documentation in a bunch of VA visits. And you may not be surprised to discover that the direction of omission or fictitious documentation is not at random. It tends to be in the direction that leads to visits being potentially upcoded, and billed for more being done than less. So I really think that this is a systemic problem that we need to be looking at the human interface design of electronic medical records, and also calling attention to it generally.
Yes, thanks. And Matt asked a related question, Alan, for a documentation. Can you tell what was actually entered by the provider versus, like an EHR template?
That's a great question. What we get back looks sort of like the PDF of the note that comes out of the EHR. So maybe if we looked at several of them from the same practice, we could try to identify which part is has been changed and which part hasn't. All of the practices were using some kind of EHR, and all of the EHRs had some kind of templating. So I don't know if I could be specific about that.
Well, that's helpful. As I'm looking at the time, team, as we have about 10 minutes left, as this has been really great. So thank you, Abby and Alan, for your presentations and for this very enlightening discussion. I'm wondering if in the 10 minutes we have left, as both Abby has some additional questions that we haven't answered, and Alan, you have some additional questions we haven't gotten to. Would you both like to look at the chat and see which questions that you'd like to answer, or would you like me to continue selecting questions for you to answer, and we can do a little more back and forth? Just wanting to make sure that we give everyone a chance to be a part of the discussion. Do Abby and Alan, do you have preferences on how we take these last 10 minutes?
No preference.
No preference.
All right. Well, then, to just get you off of the hot seat, so to speak, Alan, as you've been answering a number of questions, how about we then come back to Abby for a question?
Sure.
Let's see, as I'm going up here. Abby, was there one that you wanted to answer, or you want me to just pick one at random?
I like this idea that I'm just looking at some of these, the thoughts on measuring cognitive load post-encounter psychometrically. Are we missing variations in cognitive load during the process of clinical reasoning? And I think that's a great question, just methodologically. And I think the answer is probably yes. In fact, one of the measures that we use in some of the qualitative work is that we look at the language, not necessarily at this point yet the language they use during the, say, the simulated encounter, but at the language, we ask them all to do these think aloud reflections at the end where they rewatch the video, and we ask them to talk about what they had been thinking in terms of their clinical reasoning process as they went through it. And what we noted was that there were some variations in language as some of those contextual factors came up. Things like pauses and repeating a word several times, some ums and ahs, some things like what I'm doing right now, maybes, probably, sort of, those kinds of things. So I do think it's important to measure cognitive load during the, although it may be hard to measure during the encounter itself, although maybe that can be done too. I think measuring it at least as folks are reflecting about the encounter is important. it may be easier to grab cognitive load during an encounter if you have some sort of team medicine going on. There's been some really great work on capturing cognitive load linguistically with teams of people trying to put out fires through this online fire system working together. So when folks work together, they have to talk to each other, and when they talk to each other, you can sometimes pick up that cognitive.
Thank you, Abby, for that summary that addressed several of the questions in the chat. As I know we're getting close to time, I'll lob it back over to Alan. Alan, are there any questions in the chat that were particularly compelling, or would you like me to just pick one or two at random?
Why don't you go at random? I love random.
All right. So one question was, did all the patients present with severe depression and/or with suicidal ideation?
That's great. So no, none of the patients presented with severe depression or suicidal ideation. They presented with what would be a positive depression screen, suggesting that they ought to be referred for a workup. But we didn't have any patients present in a situation that would be emergent, right? We didn't want the physician to look at the depression screen and send them to the ER.
Great, thank you. And I know that, I believe that John has a question. Is John still on the line?
Yes, a couple actually. One was that you've talked about the process of care, but not outcomes, not patient outcomes. And I wondered if you had any thoughts about extending your research to look at patient outcomes. For example, a score on a depression scale or suicide or that sort of thing. The other question has to do with you were curious as to why physicians don't ask about depression. There was a study done many years ago now reported in JAMA called "Why Don't Physicians Ask About Domestic Abuse?" Opening Pandora's Box. So I think one reason physicians don't ask about depression is that it would be opening Pandora's box. In other words, it would put you behind on your schedule. And so an intervention might be to help physicians deal with this quickly. In other words, you've got hypertension, you've got diabetes, and oh, by the way, you have depression. The hypertension and diabetes might take 10 or 15 minutes. The depression might take much longer. What can we do today? We can ask about suicidal ideation. We can write a prescription for Prozac, and we can see you back in a week, or something else.
Yeah, so I'll take the second one first, and I think that's a great idea. I mean, so of course people are reluctant to do things that either they feel they're not going to do well or they feel they don't have time to do, right? So one concern is, maybe I won't ask because I wouldn't know what to do. The nice thing about depression is that if you ask physicians, what would you do with a depressed patient, they know what to do at minimum, right? They would say, well, I would try to get a consult. Okay, great, right? And I think having standing orders or some other kinds of guidelines of the sort you're describing, a way to make that process fast and simple would be a help. It will never be a substitute for the clinical acumen and humanism of a physician. We can't just feed the PHQ-9 into Watson and have it spit back the referral. I think that's going to be ineffective for patients. They need doctors. But I think that is a really fair point. And as I said, all of these folks, all of these cases were coming in with other things, right? With low back pain or with their diabetes going out of control and so on. So the physicians were dealing with more than one kind of problem at once, which is, for the typical intern is a pretty typical situation. Your first question was about, patient outcomes. Yes. So obviously we don't study the outcomes to our actors because they're not real patients and they don't have real outcomes. In this study, the closest we could get was looking at claims, which is, of course, not really patient outcomes. But in past research that we've done where we've used other methods of direct observation, in particular, having real patients carry concealed audio recorders and coding what goes on in actual visits rather than in visits with fake patients, We have in the VA looked at things like whether the clinicians attempt to probe for patient factors in their life that ought to affect their care, but are not strictly medical factors. Things like trouble reading in English, low English proficiency, for example. Whether when physicians ask about those things and address them when they find them, it leads to improved health outcomes in patients. And we do have a study out of the VA where we did find that 6 to 9 months later, patients got better when their physicians did that. And so we have some major QI programs going on in 6 or 7 VAs trying to help physicians learn better how to probe those kinds of, we call them contextual factors too, but there are different contextual factors than ABIs.
Thank you for that answer and for those questions. And I know we're right at the hour, so I just wanted to end with thanking Abby and Alan for their excellent presentations and their really great work. Wanted to thank you all for a great discussion and the questions that were posed and the discussion that ensued. And Mark Graber stole my thunder in stating that if you like these 2 papers, there actually is a special issue on situativity, which was one of the theories that Abby mentioned, that's a part of Diagnosis. And Mark Graber actually put the link into the special issue if you'd like to read more about the papers that were included in that. Again, wanted to thank you all for your time and your attention, and hope you all stay safe and well, and look forward to the next Journal Club. Bye, everybody.